Welcome to this webinar on incident management presented by the Australian Council on Healthcare Standards on behalf of the New South Wales Ministry of Health and the Network of Alcohol and Other Drug Agencies, or NADA. My name is Associate Professor Peter Hibbert. I work at the Australian Institute of Health Innovation at Macquarie University, and then I'm also a member of the faculty of the ACHS Improvement Academy. And it's my pleasure to also introduce Associate Professor Bernie Harrison, who's the Director of the ACHS Improvement Academy.
Hello everyone, and it's a pleasure to be presenting this webinar with you today. ACHS has already run 4 face-to-face workshops for the sector, and this webinar summarises some of the key high-level principles, if you like, of incident management that was also shown at those workshops. I'm going to be posing some questions to Peter, if you like, standing in your shoes, and hearing his responses to those questions. So thank you. Thanks,
Bernie.
So Peter, what do we want to achieve today out of this webinar?
Thanks, Bernie. So what we'd like to do is just give an overview of incident management systems. And then the second thing is really a set of principles around viewing clinical incidents as an opportunity for individuals and organisations to reflect on practice with a no-fault view, and then to use those learnings to improve practice and client experience of service. So essentially what that means is we are taking a systems perspective when incidents occur. We're acknowledging that errors do happen, but what we're looking at is to examine the system and then try and improve it, and therefore to try and reduce the chance of incidents happening again. Then we're going to look at the types of clinical incidents that are occurring, particularly serious and non-serious. And the reason for that is they will be dealt with differently using different processes. So we will try and understand those incidents. Then we'll go through the management of those two types of incidents, and how to manage them. We will also look at what are the obligations and processes to communicate clinical incidents from the NGO to the local health network and or the Ministry of Health. And then towards the end, we'll look at what sort of processes are needed to analyse and report on the types of clinical incidents that occur over time.
Good. So New South Wales, we know, funds over 50 government organisations, NGOs. Can you just tell us a little bit about what services those are?
Sure. Now that funding's provided to NGOs for alcohol and other drug treatment through a variety of grants and service arrangements, and those treatment types are primarily withdrawal management, psychosocial counselling, residential treatment, day programs, and outreach.
So can you tell us a little bit about the background to this, the whole incident management system that's being adopted by NADA and the department?
Sure. So from mid last year, which is 2018, NGOs contracted by New South Wales Health to provide these sorts of services, so alcohol and other drug services. They have 5 core performance indicators that are actually included in the contracts. In addition to this, the Ministry and NADA are developing a set of protocols for clinical incident management. And at this point in time, in late 2019, they are still consulting on those protocols, and they will be released in early 2020.
Okay, so can you tell us a little bit more about the 5 performance indicators?
Yes, so there's 5. The first one is around a New South Wales minimum data set, so collecting data for the sector. The second one is being for the NGOs to be involved in accreditation and clinical governance. The third is around collecting data around client reported experience. The fourth is around clinical incident management. And the fifth is around collecting data around client discharge and transfer of care. And today we're just focusing on the fourth one, so clinical incident management.
Good. So let's hear a little bit more about the clinical incident management system.
Sure. So essentially, what this performance indicator says at a broad principle kind of level is that a funded service should have a clinical incident management in place, which aligns with the New South Wales Health Clinical Incident Management Policy and Guidelines, which I'll talk about a bit later.
So that's the one that's used by the whole of New South Wales Health.
Yes, yeah, that's the one.
Yeah.
And so the system will, that clinical incident system that will manage all clinical incidents and also report serious clinical incidents. And then there's essentially a process. So those clinical incidents are identified, appropriately responded to, reported, and then that information is used to improve the safety and quality of care that's delivered to clients. There's also, it ensures that there is a process for communicating serious clinical incidents to the local health district or LHD and or the Ministry of Health at the time of the incident. We'll talk about that a bit later. And then also that clinical incident data is analysed and collated in reports over time for internal and also for external use.
So for people who might not be entirely sure, what would be a serious clinical incident in the context of the service?
So we'll go through the actual definitions later, but in terms of a service, it could be an overdose, it could be serious self-harm or suicide, it could be aggression and violence that is directed to another client. So it's those sorts of incidents that have a serious outcome to the client.
Good, thank you.
We've already mentioned the New South Wales Incident Management Policy, and I've put it up on the screen. This is available for download from the website of New South Wales Health. It's recently been updated, so you can see the publication date is on the 25th of July 2019. The local health districts and other New South Wales health organisations have used a version of this policy for a number of years. So this policy outlines a set of principles and a step-by-step process for managing incidents. It's directed for New South Wales health bodies, and it's really the principles that there is an expectation for NGOs to be in alignment with their own incident management policies. I'm going to go through some high-level principles now from this policy. So the first one is about openness about failures. So this is incidents are reported and acknowledged without fear of inappropriate blame. So the first thing, if workers or staff at an NGO don't feel safe and don't feel comfortable reporting incidents, then the NGO is not going to be aware of those incidents, and therefore they are not going to be managed. So it is important that that management and executive at the level of the NGO have a culture where staff feel that they are comfortable to report these incidents. Secondly, that when those incidents are reported, that clients and their families are offered an apology and are told what went wrong and why. And part of the investigation process that we're going to be talking about today is to help facilitate that process. So factual information can be provided to families when something goes wrong. There's an emphasis on learning. So this is that the system is orientated towards learning from mistakes and consistently employs improvement methods for achieving this. Essentially, as I opened up with this webinar, that what we're trying to do is understand that errors do occur, but errors occur in an environment where a system might facilitate an error occurring. So what we want to do is try and understand that system, improve the system, and then try and reduce the chance of errors happening again. The organisation has an obligation to act, and that is to take action to remedy problems. That's clearly accepted, and the allocation of this responsibility is unambiguous and explicit. So essentially what that's saying is management and executive really understand their roles and responsibility, that in incident management is one of those core roles and responsibilities. The last one here is accountability. So the limits of individual accountability are clear, and then that individuals understand where they may be held accountable for their actions. So the vast majority of things that go wrong, of incidents that occur, relate to the system, but a small proportion, and which are relatively infrequent, may be related to an individual's performance or behavior or competence. When that occurs, a separate type of investigation will occur. So that will be more along the lines of human resources or a performance management process. But it's clear when that's occurring. What we're talking about today is primarily a systems investigation.
So one of the common questions that people want to know about is, we do an incident review and we find that somebody hasn't followed a policy or procedure. Is that something that would need to be reported to HR, or is that something that we would manage through the incident process?
Most of the time, even though a policy and procedure might not have been followed, we try and understand whether that staff member was trying to deliberately harm a client, or indeed their actions were reckless or highly risky. What's generally happening though when a policy or procedure is not being followed is we need to try and understand why that occurred. It's often because the policy and procedure might not have been clear. So that process might not have been clear, or at that particular point in time, there might have been a staffing shortage. So if there needed to be a double check, say for medications, and there was something else going on in the facility, then it was actually very difficult or indeed impossible for that rule to be followed at that particular point in time. So unless we can say that that behavior was reckless or deliberate harm was involved, then we generally still take the systems perspective.
Good, thank you.
And that brings on to the next point, that individuals, so staff or individuals, are treated fairly when these processes happen. So we don't leap into the blame space. So automatically when something has gone wrong, we take a methodical perspective and try and understand the system. If there is reckless behavior or there is inappropriate behavior towards clients, then we do need to go down an accountability perspective, but that will be a less frequent process than the systems. The next point is appropriate prioritization of actions, and this is action to address problems is prioritizing resources directed to the areas where the greatest improvements are possible. So we will be undertaking investigations for when things go wrong, but it's also to acknowledge that we need to direct resources to the most frequent and to those incidents that afford the greatest harm to clients. So what this implies is NGOs need to do analyses of their incidents that have occurred in the last, say, 6 or 12 months, and then use that analysis with other data to then direct quality improvement or practice improvement activities. So it really is about putting the right amount of resources to those incidents which are most frequent and create most harm for clients. The last principle is around cooperation, collaboration, and teamwork. So our experience of years of looking at incident reports, of serious incident reports, has led us to the conclusion that things like teamwork, handover, communication within the clinical workspace are the best defense for systems failures. And so a really important improvement mechanism is to, on a day-to-day basis, improving those processes, so those teamwork and handover processes.
Good. Thank you. So really the key message here is to stay focused on the systems rather than individuals.
Yeah.
And unless we have direct evidence of reckless intent or abuse or criminal activity, we are confident and comfortable to stay very much focused on the systems.
Yes, and we might be labouring this point a bit, but it's for a reason. So that unless we get this right to start with, then we're going to be going down the wrong. We're going to be going down the wrong path. So for most incidents, we are identifying systems issues within the NGO and developing recommendations directed towards that system.
Yeah.
If during the course of the investigation, or even before the investigation starts, early on, so we recognise that individual clinician performance, competence, behaviour, significant reckless behaviour happens, then a performance management plan should be developed, and it's explicit that this is not a systems-based investigation. It really needs to be clear at that NGO level that this is different. This is about performance management.
So we'd be talking about things like somebody turning up drunk for work, or somebody stealing from a client, or fraud, or abuse.
Yeah, so physical or sexual abuse, psychological abuse. Yeah. So those sorts of behaviours. That's what we're talking about. Yeah. Or reckless breaking of the rules that is unjustified. Yeah. That might lead to, in serious cases, so where there's been a breach in a professional code of conduct, that the relevant registration body is notified, and so an external investigation is done along those lines. So it kind of brings up the question for an NGO to say, what is your process for determining clinician performance and competence? So what are the set of rules that you use, and a process with senior managers to determine that? And that's a really important systems-based process that you have in place.
Okay, so let's talk about incidents then.
Yeah,
so
sure.
Let's have a definition and a bit of a plan for how we're going to tackle this.
Yeah, so, and definition's important. So, so this definition comes from that New South Wales health policy, and it's a good definition. So an incident is any unplanned event resulting in or with the potential for injury, damage, or other loss. This includes a near miss. And so that's important because let's take the first bit. So it's an unplanned event resulting in an injury, let's say. So that implies there's harm. And so if we just use the client example, there's harm to a client, or an injury to a client. But it also includes those incidents with the potential. So it may be that a client has an overdose and they don't get harmed, but if we look at it from a systems perspective, there may be areas where we can prevent that overdose occurring or being detected early. So it's not just those incidents that result in harm. So that's why we're explicit about saying it's a near miss. It's a definition that's deliberately broad, so it can encompass a big range of things that can go wrong. So either directed towards the client or staff injuries or even towards the organisation. So there could be a fire or there could be an information breach. Okay, so potentially information around privacy could be lost. So that can include it as well. So that's why it's deliberately broad. And from a client perspective, there's a number of things that it can be involved. So there can be medications or falls or incidents to do with clinical equipment or non-clinical equipment, around, say, duress alarms, self-harm, suicides, aggression and violence directed towards staff or clients, problems with IT or information systems, documentation failures, planning failures of clients or communication. So it's a pretty broad brush in terms of what is an incident and whether it's severe or non-serious. Severe or non-serious. So then the next question is, so if we've got an incident type, then whether the incident is serious or non-serious. And this is important for the AOD sector because these are managed quite differently. And so I'm going to take you next along what is a serious incident and in a bit of detail how that's actually managed, and then we'll look at non-serious incidents and with less detail that about how these are managed. So firstly, we have an incident that occurs and within an NGO, and an NGO recognises that it's a serious incident. So how do they do that? How do we determine that it is a serious incident? We do this using the Severity Assessment Code. So there's a schema of the code that's up on the screen at the moment. This has been used within the Ministry of Health Services, such as LHDs, for over a decade, and it will be the primary system that we use in the AOD sector as well to determine seriousness of incident. It actually came from the Australian. It's a modification of the Australian and New Zealand risk management framework that's been around for many years. So there's a 3-step process that's used to determine the Severity Assessment Code, or SAC, rating. The first is to determine the consequence of the incident. So this is the horizontal axis that is highlighted on the slide. So the consequence can be rated as serious, major, moderate, minor, or minimum. And this can be directed towards the client, towards staff, or a visitor, so if a visitor gets injured, or indeed from an organisation perspective, so like an information breach or a fire. The definitions that are currently used within the Ministry of Health are quite focused on clinical incidents in acute services, such as health services, such as within LHDs. And at the moment, as this webinar is going to air, different definitions are being developed that are more suited to the AOD sector. And so the department and NADA are going through a consultation process for the sector to help develop definitions that are more relevant for the sector. Nevertheless, the category terms will be the same. So they will be serious, major, moderate, minor, and minimum. So that's the first step. The next step is to is to understand or make a judgment on how likely this incident is to occur again. And again, definitions will be forwarded from the Ministry of Health and for NADA for the sector. But the broad categories are, is it likely to happen frequently, likely, possible, unlikely, or rarely? From those two axes, a SAC rating from 1 to 4 can be developed. So if the consequence is considered moderate and then the likely is considered likely, then that is scored as a SAC rating 2. If the consequence is considered moderate and the likelihood is considered unlikely, that is considered a SAC rating 3. And then clearly from this table, SAC ratings are either 1, 2, 3, or 4. So for the AOD sector, a SAC 1 or 2 is a serious incident, and a SAC 3 or 4 is a non-serious incident. I'm now going to talk through what is the process for a serious incident, so a SAC 1 or 2. The first thing that needs to happen is an NGO manager takes immediate action to mitigate any harmful consequences towards the client, so they make the client safe, and there is a notification process to the AOD branch as soon as possible, and that means within 24 hours or the next business day. So, and then the AOD manager submits an incident report to the AOD branch within 24 hours or the next business day. So what does that look like? That essentially means a telephone call to the AOD branch or the LHD to which the AOD has the major contract, and that's a telephone call, and then there will be an incident report. The Ministry of Health will be producing suggested templates for these incident reports. So, and that gives a set of essentially the fields and the information that is required to be reported as part of that incident report.
So when are they likely to be available?
So in 2020, okay. So early next year. So the ministry and NADA are continuing to consult on what they look like. So the next step is prioritization, and this is at the level of the AOD branch. So not at NADA, but this is actions for the AOD branch. Essentially, the clinical incident response leaders, they look at that incident and the descriptor of what the NGO has provided, and try and make a confirmation rating that yes, it is a SAC 1 or 2, it is a serious incident, and then they prioritise that within their workload. There's an escalation process within the AOD and also the Centre for Population Health, and then the incident is recorded in the serious clinical incident register, and then reported to the Incident Information Management System, or IMS, as appropriate. Now, IMS is a system that's been used for about a decade within the Ministry of Health and the department to record and manage incidents. It is not the incident system that the NGO will be using, so it's the internal system that the ministry will use to record these serious incidents. So it's their process, but it's useful for you to know the acronym of what IMS is. Those clinical incidents that have been reviewed by the AOD branch and determined not to be serious incidents will be investigated by the NGO, recorded according to local processes. So just to be clear, those incidents will be handed back to the NGO, and that will happen from from time to time, that the NGO will believe that it's a SAC 1 or 2, it's a serious incident. They'll escalate it up to the AOD branch, and then the AOD branch will say, actually, it's not. Now, this is not a bad thing. That if the NGO escalates it up and it's not, and that's the NGO in some ways being cautious. And I think over time, the whole sector will understand to a greater degree what these serious incidents look like. So from time to time, that will happen. Those clinical incidents that are confirmed as SAC 1 or 2, they will be investigated not by the NGO, but by the AOD using the London Protocol technique.
Right, so we know that there's an RCA investigation method used by the Department of Health. So tell us a bit more about the London Protocol and where it differs and what's the same.
Yeah, okay. All right. So, so the AOD branch will investigate these incidents. They'll enter the details into the IMS branch. They'll then undertake this London Protocol investigation in consultation with the NGO, and the AOD will have 45 days to, which is actually the same as the RCAs, and then that report will be submitted to the Centre for Population Health Director, and also the Quality and the Safety and Quality Director for the AOD branch.
So it all sounds quite complicated. So locally there's an investigation, but there's also a requirement to report to the department through alcohol and other drug services. So what's the purpose of that reporting?
Yeah, so there's a couple of purposes. So one is an independent investigation can be done. So so a really robust process can occur, which then allows learning for that particular incident to occur, and then also recommendations to be actions. And then what that does locally is that reduces the chances of that particular incident occurring again. But there's also a systems perspective. If you take a broad view of the sector, it's really valuable to see all the serious incidents that are occurring at a sector level, and then to learn from those. And so if you can use examples of particular medications, reactions, or you could even use information systems that, say, client information systems that are being used across the sector, that might actually pose some risks in terms of not presenting the right information to the right time around clients. And so what that allows the branch to do is to say, these incidents are happening at the different NGOs, and so we'll be putting out some broad sector-wide recommendations. So it's around sector-wide learning for those incidents, not just about local learning for one particular NGO.
Yeah, so it's possible for one person to think they only have the problem, but in point of fact, across the 50 services, all 50 are having the problem.
Indeed.
And then it requires an overall system response.
Yeah. And sometimes it's more efficient to actually put a recommendation across a whole sector rather than 50 NGOs having to learn 50 times. So we're doing this investigation. So it's the AOD who are actually doing this London Protocol investigation. Clearly, they do it in consultation with the NGO, and the AOD branch have 45 days to undergo that investigation, and then that's submitted into the Centre for Population Health Director, and then also into the AOD branch. The London Protocol, it's a reflective investigation process, it's systems-based, and the purpose is to use the incident to reflect on what does it tell us in terms of gaps and inadequacies that it reveals in the healthcare system and the AOD sector. It identifies care delivery problems and highlights contributory factors for the incident. And then each of these factors can serve as a starting point to drill down to root causes, and then moving on to developing recommendations.
So it'd be fair to say it's very similar to the root cause analysis.
It is,
investigation for
yes.
people who've done that one.
Yeah, if you've been involved in a root cause analysis, or you've on a team, then it feels very similar.
Yeah.
The aims are similar, the objectives are similar. And this is a really high level schema that I'm not going to go into detail, but just some key points for this process. So essentially, yes, we've identified that there's been a serious incident. There's been a decision to investigate. We have a small investigation team that is put together at the AOD branch. That's looking like 3 or 4 people. It's a combination of people who have expertise in the particular service type where the incident occurred, and then also people who have investigation skills. So on how to do these sorts of investigations. So the team gets pulled together. They go out to their NGO, and probably the most important phase is this organisation and data gathering. So they will review the clients, the relevant clients' clinical notes. They will also look at other relevant documentation, say around the NGO's policy and guidelines that are relevant to the incident. They might look at maintenance schedules. So if there was an incident related to equipment, they might walk through the clinical incident management system or the documentation system that the NGO uses. And then really importantly, they conduct interviews with staff who are involved in the incident. And it's really important to distinguish these interviews that are based on systems rather than performance management interviews. All that data is pulled together. So to create an incident chronology, which is just a set of incidents that occurred related to the serious harm that happens, and that's a really important process. So when the report's produced, a cold reader who's not involved in the incident can really understand what occurred. From there, we identify the things that went wrong, so the care delivery problems, the contributory factors, and directly make recommendations and action plans based on those contributory factors. When you undertake a London protocol, this is the model that's used that I'm not going to go into detail, but we have an incident occurs. NGOs and organisations set up barriers to incidents occurring, having safe staff, safe systems, policies and procedures. Those defences and barriers are not perfect, and we have care delivery problems in that errors are made. We understand that and we acknowledge that. But where we're trying to focus our investigation is on the left-hand side of this diagram. So we're looking at contributory factors and we're looking at the organisation, management and culture. And it's there we direct our recommendations towards improving the system. We also use a contributing factors framework. Again, I'm not going to go into detail with this, but you'll see that these are all systems based. So, and these are primarily why these incidents occur.
And I guess it'd be fair to say, I'm just looking at one here, for example, for where we look at patient factors, if there are specific things like somebody who has a serious mental illness or a drug addiction, which means care and management can be made more complicated by that.
Yeah, and that's taken into account.
That's taken into account.
So, and context is, context is really important. You can also see things like in mid-level, so the work environment factors. So, workload could be a factor. And you mentioned earlier on about someone not following a protocol. So we may be able to explain that it was impossible for that protocol to be followed to the letter, how it's written down, because the workload at that particular point in time was such that it just was not doable. And so it is trying to explain the context within which people work and their actions at the time.
Yeah, and evidence tells us that if we get to those things, we've got a much, much better chance of systems improvement.
Yeah. Because, you can either just keep sacking everyone who makes an error. That's one way of doing it. Or you can try and change the system in which people are working. And that's a much more sustainable way of working.
And evidence-based.
Yeah.
So let's get into recommendations. This is
Yes, it is. So you've done all this work, and you've come up with what's happened, why it's happened, and now you need to come up with a set of recommendations. This is an important principle that the AOD branch will be using when they develop their recommendation. It's called the hierarchy of recommendations, or the hierarchy of controls. It's used in work health safety as well. So it's not just related to client-based incidents, but it's a set of principles that we use to try and develop recommendations that are as effective and sustainable as possible. Because we've done all this work, and so it's important that we develop these recommendations that are effective and sustainable. Essentially, what we're trying to say here with this hierarchy of recommendations is the ones that are strong are those that are less reliant on staff remembering to do the right thing, and they're kind of baked into the system. Or the weak ones are more reliant on staff remembering to do the right thing. So they are less sustainable, and they are less effective. We're not saying that policies, procedures, and training are not important, and we're saying that they're kind of bad. What we are saying is that they need to be, where possible, enhanced by more systems-based recommendations. And within the team, within the London Protocol team, the question will be asked once the contributing factors are developed and they're starting to develop recommendations. They'll ask themselves, how can we make this recommendation stronger? And it's an important principle for internal investigations too. So if you are doing internal investigations, then using these sorts of principles can be important.
So, it'd be fair to say, as we read the list, this is, and I think many of us would see this, it'd be interesting to have your comment on that. The strong one seems to be much more linked to how care is delivered, if you like, in the microsystem where real work occurs, where these weaker ones are sort of further back in terms of policies and governance and things that might come down from a department, say. Is that what's going on here? Yeah,
we're really trying to change how people work and their relationship and the way they work between them and the client. So actually how the work happens within the service.
So work as done as opposed to work as imagined.
Yeah. So recommendations will be developed and they'll be presented in a table like this. So it may not look exactly like this, but we just want to show you this just to make a couple of points. The first point is that recommendations are not random, that they are linked to contributory factors. So these are the contributory factors that are found within the London Protocol investigation. So there's a direct link between contributory factors and actions or investigations, which is the second column. The third column is where the recommendations are kind of focused. And then importantly, someone within the NGO needs to have responsibility for this recommendation to actually happen. So it's not just someone senior needs to make sure that this is actually going to happen, and it's going to happen by a particular point in time. So if these recommendations are not allocated to people and they're not allocated within the timeline, they're less likely to occur. It's important to understand what are the resource requirements and what does the NGO need to do so they can be reasonably certain that the recommendation is done. You, Bernie, you talked about what you mentioned root cause analysis before, and that they are similar. And so what's the difference between a root cause analysis and a London Protocol? It's a really important distinction, and especially for those people who have been involved in, possibly processes within LHN or other ministry services. So when there's a clinical SAC1 event or incident occurring at a LHN, the LHN is obliged to carry out a root cause analysis investigation, and there's legislation. So there's New South Wales legislation, and that's done under that legislation. And this is referred to as a privileged RCA and has certain protections for the RCA team and the participants in terms of the documents that are produced and around the interviews. The important distinction is that the London Protocol process for AOD does not have these protections. So even though the two processes of investigation might look and feel similar, it's important that we've called it something else. So it's called a London Protocol because, just to make sure that people don't confuse, that those RCA protections apply to these London Protocol investigations.
But can I just clarify that even without privilege, there are confidentiality, if you like, requirements of people doing a London Protocol with respect to confidential client information and staff information.
Yeah.
So that still holds.
That still holds.
Yeah.
So what happens if I'm interviewed? So I'm a staff member. I've been involved in an incident. In an incident. So the AOD branch come along and interview me and do a systems-based investigation. What I say in that interview just gets collated as part of that investigation. It's not, what I say is not allocated towards me. That's not shared with anyone else. And all the interviews and all the data is pulled together to then come up with a story. So in terms of what happened and how that information is gathered and who said what is not part of the process. Okay, so there's this kind of a de-identification process that occurs, and that's a really important point so people can feel comfortable when they were being interviewed that what they say is not being ascribed to them.
Yeah, and I think as well under the New South Wales SAC RCA legislation, SAC1 RCA legislation, one of the key things there is it prevents and prohibits the RCA team from investigating an individual. And that is the same with the London Protocol.
Yes, yeah.
So you cannot use that process to go and investigate an individual.
Yes.
Is that correct?
Yes, that's right.
Right.
Yeah.
You have to use another process.
You have to use another process. Yeah.
So in that respect, they're quite similar.
Yeah, that's right. So again, this goes back to this is systems. This is London Protocol is systems based, and if there's reckless behaviour, if there's abuse, we go down another pathway. Yeah.
So thanks for clarifying that.
No, it's so. If the investigation's done, then the AOD complete the investigation. They record and classify the incident type and contributing factors and within the incident, within their own IM system. But as we said before, their role is to identify emerging themes that are contributing to incidents. So, and those incidents might be occurring across NGOs. So they're having that bird's eye view and to say, look, there's common incidents that are occurring. So around information management or how we are monitoring medications within our residential services, for instance. So we might put some recommendations out across the service. And then this last point is around the implementation of recommendations. This is the NGO's role. So after the investigation has finished, the AOD branch hands over those recommendations to the NGO, and essentially it's the NGO's role and responsibility to ensure that those recommendations are robustly put in place to try and reduce the chance of this happening again.
So that's the serious incidents. So what about the managing non-serious incidents when there isn't evidence of harm or other issues, but potentially a near miss or could have been?
Yeah, sure. So I've showed you this diagram before. So again, this is just to make sure we're distinguishing ourselves between the serious and the non-serious ones, which I'm going to briefly talk about now. Again, to remind ourselves that the way we determine this is via our SAC code. So we use the consequence, we use the likelihood to determine the SAC code. And then from there, if it's SAC 3 or 4, it's a non-serious incident. The steps for the non-serious incident, I'd like to refer you back to the New South Wales Clinical the Incident Management Policy. That's got some really nice principles. It's got a set of steps that you can work through. Note the steps are similar to when we're talking about serious incidents, but there's two, just really to emphasize the point, there's two distinguishing features between serious and non-serious incident management. The first one is that the non-serious are not communicated to the Ministry of Health. So the serious ones are, the not serious ones are not communicated to the Ministry of Health or the AOD. The second distinguishing feature is these non-serious incidents are managed in-house. So an internal, we can use the word investigation or analysis process occurs, and that's done using a similar process, but clearly the resources that are required compared to a serious incident are much less. You can use things like a contributing factors framework. You can use same processes, gathering information, but you're just not going to be using the same number of or sets of resources that the AOD branch will do with their serious incidents.
So are you able to give us an example of a non-serious incident so we kind of understand what that sort of thing might be?
Yeah, and they can look very similar to a serious incident. So it could be someone who leaves a facility but is not who leaves a facility but they don't come to harm, but they're not detected that they've left for a while. There could be an aggression or violence incident. There could be a fall, or it could be around a duress alarm that doesn't go off, okay, but no one's harmed. So there's a bunch of things that, or it could be a medication incident. Again, someone could be exposed to a medication or an overdose that's potentially serious, but there's minimal harm.
Yep.
Okay.
Yep.
So often the why, quite similar between the serious and the non-serious, but it's the outcome that's important. And really, I think the key point to get across is that those non-serious incidents are undertaken at local level, but also it's important to aggregate it's often important to aggregate a number of non-serious incidents and perform a review of several incidents at a time. And looking at those incidents, across time can really help inform what requires a practice improvement project, rather than doing, one incident and then the next incident and the next incident. So trying to theme them up into what are common things that are happening is important.
So if I can just take your duress alarm example. So if we've got a product that falsely alarms,
but
there's no harm to the client, but it's obviously an issue. We wouldn't do a very in-depth review of that, but if we had 10 or 15 or 20 in a week, we might go back and review that product and say, and you do it, and then you do them as a set. Yes. Yeah, I get that.
Because each one will tell you something slightly different about that. But collectively, you'll then come to the view that at a particular point in time, and at a particular set of circumstances, when that duress alarm is being used, there is something inappropriate going on and we need to change the system.
Yeah. And what are the data and evidence reporting requirements for NGOs?
Okay.
Which are under Core 4, which we talked about before, which is the clinical incident management responsibility.
Yeah, okay. So I'll talk about that now. So moving on from the non-serious investigation or analysis side of things, we'll talk about the Core 4. And really there's a couple of questions I can pose for NGOs. So do you have a current incident policy and protocol, and that's a obligation under these performance indicators? There's lots of them on the internet, from similar organisations. They tend to look like the New South Wales one, and it's important to align with the New South Wales one. They often take that same process of breaking the incident up into a set of phases, and then also trying to really be clear about what are roles and responsibilities of people within the organisation. So things like who needs to confirm that SAC rating, who does an internal investigation, who undertakes the analysis of information and those aggregated analyses. So there's those sorts of things that need to be answered by the incident policy and protocol. And then the other obligation is that organisations or NGOs need to have clinical incident data analysis and trend reports and improvement plans. These are a 6-monthly process, and they're reported on the 21st day of the month following the 6-month period of data collection. So these are what we mean by data analysis and trend reports: a summary interpretation of data which has been collected over time to show changes or patterns in the reporting period, which can then be used to report to improve services and practices. And I'll just make the point that 3 out of the 5 AOD-Core performance indicators have those data analysis and trend reports as part of their reporting requirements. So I suppose it's an important capability to have those, to have some skills within the organisation to do those data analysis and trend reports. And you do know people, everyone knows within their organisation, those people who are good with data, so who can do these sorts of reports. So, I would encourage you to use those people who know their way around a spreadsheet and how to report these sorts of things. If we just concentrate on the clinical incident management one, the goals of the report are to identify trends in the rates and types of clinical incidents occurring during service delivery, discuss key factors influencing those trends, and inform service improvements in response to identified trends. So in some ways, you could say those 3 points are what's happening, why they're happening, and what are we doing to improve that service and to stop it happening again. There's some data that is outlined in terms of number of clinical incidents, their rates, and their incident categories over the 6-month reporting period, and then describe the changes or trends identified in the data shown. So that's kind of the core requirements of that performance indicator. I would like to make the point, though, that that many NGOs have low numbers of incidents, and so I think it's important for those NGOs to not necessarily to get too hung up on the numbers. To say, say if they've had 10 incidents happen for this 6 months and they had 8 happening the previous 6 months. So not if you've got low numbers of incidents like that, to not worry too much about those raw numbers, but really to provide descriptive, qualitative sort of analyses of what's happening and why. And I think, for those low numbers, and if you are getting, dozens or 100 or something like that of incidents occurring, then you might concentrate on numbers a bit more, but with the low numbers of incidents, be more descriptive. And there's a couple of good examples on the website for the core incident management principles. So this one is one that I've directly lifted off the website, that says discuss the key factors which influence this change or trend. And it shows that an example of an NGO has said, we've noticed an increase in clients with stimulants as their principal drug of concern utilising the service. This may account for both the increase in the rates of incidents and the emergence of client aggression as the dominant clinical incident type. So it's really providing a good descriptor of what's happening behind the I suppose the profile of the incidents, without getting hung up on the numbers. And then there is a similar one with the actions, outcomes, and improvement plans as a result of the data trend analysis. So this is the NGO is saying we've got several strategies that have been implemented to reduce the number of behaviour incidents that they're undertaking. And this is really what the ministry and NADA want to see. They want to see a robust response to incidents occurring, and that the response is a serious response. It's done within the right culture, and it's done within a systems based. Okay, so you're really trying to change the system to improve the service, and I think this gives a good example of that.
Yeah, I agree. This is a great example, and I presume as well, people would be encouraged to look at exemplars around the world and look at best practice in managing aggression and behavioural issues. And it's great to see that sort of innovation around providing de-escalation and chill out spaces rather than more medication, restraint, physical and chemical restraint being used. So you can see that this drives improvement. So that's I think that's a very, very good example.
Yeah, and these reports get sent to AOD. We can also emphasise that just like the investigations can be, the learnings from the individual investigations can be shared at a systems level, so also what people are doing about it can also be aggregated by the AOD. So
scaled up and spread, if you like.
Say, these organisations seem to be having success with certain recommendations, and so you can actually use that as a systems level quality improvement process that can be spread across the system. And I think that's a really positive use of this data. So rather than
blame and blame.
Blaming organisations for these happening, so it's they are a really positive. They're taken in a positive light. So and I think that's a really nice it's a really nice point to finish on that. Just to emphasise, at the level at which these are happening with staff, that that we want to learn, but also we want to learn from a whole sector, and that's really why this system is being put in place.
Good. Well, thank you very much, Peter.